Okay, this is just an update message. I hope the course is going well for you. The first quiz, everyone has done a great job on it. The rest of the quizzes will be very similar in their nature. Um, the next quiz that's coming up over cardiopulmonary and all that stuff, you'll have 4 hours to take it. The lectures for that were the ones I did from last year. I thought that those were okay. I think there's a bonus question that I talked about in there for why does an ACE inhibitor cause a cough? That bonus question is legitimate, so email me your answer, um, and that's two easy bonus points. Um, Discussion board. The answers are very accurate. You've all done a good job. I'm probably not going to respond to those individually, which is why I want to give you a whole group response. So the $4 list is an important thing, and I'll tell you what made me realize that when I first started practicing. Uh, my main mentor, who was this physician from Africa, he was always telling me about how he practiced medicine when he was in Africa, and he didn't have the resources that we had here. Um, and he told me that $4 list is almost all you need. And in one respect, he's actually right. There are so many medicines on the $4 list that I wasn't even aware of that treat almost everything chronic, especially things like diabetes, heart failure, heart disease, hypertension, a lot of your mainstay things, even good antibiotics. So just because a medication is new or some study says it's better, it doesn't necessarily mean anything. And if a patient can't afford it, you might as well not prescribe it because they're not going to take it, and then they're going to return to your clinic or to the hospital ill once again. So I'm not saying that's the only thing I use to prescribe medicines. There are some things that they have to have this medication, and that's all there is to it. But by and large, always remember the economic burden to your patient and how that will affect whether or not they can adhere to your treatment. So, you all picked out great selections. Here's what I do for that kind of patient: oral anti-hyperglycemics. I usually start out with metformin. Sometimes, if their glucose is super duper high and their A1C is high, I may add a sulfonylurea. And here's the thing about sulfonylureas, and we'll talk more about this in the diabetes lecture. I like them when they work, and I hate them when they work too well. Once they start causing hypoglycemia, their action in the body is very long. Their half life is very long. It takes a while to get it out and resolve that hypoglycemia. So I typically just start with metformin. The Some reference books say start out at 500 twice daily. I go for 1,000 twice daily. I seem to have better results with that. In my situation, in an acute care setting, I don't actually have the um, luxury is not the right word, but I'll use it anyways. I don't get to follow up with the patient unless they have an acute setting. In the primary setting is where diabetes is really managed. So when I diagnose a patient with diabetes in the hospital, which does happen quite a bit, as long I'll usually start with metformin. For heart failure, um, hypertension, the other things mentioned in that scenario, beta blockers, of course, that kills two birds with one stone. Okay, um, heart uh, rate and contractility as well as blood pressure. So metoprolol is good, Coreg is good. Um, it's always good to put a beta blocker on there. You need that. When an ejection fraction is at 35% or less, then the guidelines call for an ACE inhibitor as long as it's not contraindicated otherwise. In this case, the patient does not have any renal failure or allergies. So, lisinopril is always great to start with. That helps with remodeling of the left ventricle, and it also helps with hypertension. And then, of course, a diuretic. Hydrochlorothiazide doesn't count, and I'll tell you why. It's a very weak diuretic and has almost no effect on heart failure. Now, some people would select that because it does help with hypertension. That, for this patient, we're going to have enough medications that are going to treat hypertension, so I'm not too worried about hydrochlorothiazide. Lasix is always the best option, as long as it's not otherwise contraindicated. And then, of course, in a patient like this, they need to be on an aspirin. So everyone's done very well on that. Um, After this bit of content over hypertension, hyperlipidemia, cardio, and pulmonary, I'll probably start posting brand new videos because I need to kind of reorganize some of the old lectures. Um, I hope that everyone is adjusting well to the course. I am not always the most well. It's not that I'm not organized, but there are times where, hey, if something's not up at midnight today, it's going to be. Don't worry. So have patience with me, and I'll have patience with you. I know some of you have had problems with the books. Hopefully that's been straightened out. Anybody who's got a problem with anything or something's not working out with your schedule, like I say, just let me know. Nothing we can't work around. Uh, okay, I think that's all I've got for now. Everybody's doing a great job. Keep it up. And I'll have some more videos for you later. If anybody's got any comments, questions, concerns, text me, call me, leave a note on the discussion board. Just know discussion board is probably the worst way to get a hold of me. Anyways, have a good week. I'll see y'all later.